All right, everyone. I hope everyone is doing well. Welcome to another webinar. This month of September is Polycystic Ovarian Awareness Month. And so we are just bringing some awareness and acknowledgement to this month by talking a little bit about polycystic ovarian syndrome and the impact of the pelvic floor, what it does to the pelvic floor, how it presents for us within the clinic, what we see, and so on and so forth. So lots of information today. We will have the recording out for you. Just had to make sure I was recording. We will have the recording out for you once this is over and everything is uploaded. So before we get started, we will go ahead and introduce ourselves. So I have with me, I'm Dr. Juan Michelle Martin. For those of you who don't know me, I am a pelvic floor physical therapist, private practice owner here in the United States in the Atlanta metro area. Let me Okay, just give me a thumbs up, everyone, because I know Dr. Dionne was having some issues as well. So throw it in the chat. If you guys can hear me pretty okay, go ahead and put a thumbs up emoji in the chat or say yes, just so I can make sure you can hear me. Can you hear me now? All right, looks like we're doing good. All right, so I'm Dr. Juan Michelle Martin. I'm a pelvic floor physical therapist here in the Atlanta metro area. I am the owner of the Pelvic Perspective, a private practice focused on orthopedic and pelvic floor. And I see everything from just chronic pelvic pain, maternal health and wellness, and then sexual concerns, both for individuals and couples. I'm also an assistant professor, and I enjoy bringing information like this to you guys. And so, yeah, I will turn it over to Dr. Dionne so that she can introduce herself.
Awesome. Because I was having audio issues earlier, I just want to make sure you're able to hear me.
I can hear you quite well. Yes.
Awesome. Thank you. Sorry, the audio issues were on my end with the different speakers and all. But good afternoon or good evening, everyone, depending on where you're joining us from. My name is Dr. Dionne Middlebrooks. I am a physical therapist as well. I own Rain Physical Therapy and Wellness, which is a practice in outside the Atlanta, Georgia area, so within that metropolitan region. I am also, in addition to ordinate practice, I'm also an adjunct professor. I take a few birth doula clients here and there throughout the year, and I have the joy of chasing around my children as my husband and I homeschool. So life is definitely joyous chaos. That's just a snapshot of some of what I do. But I'm so excited that you all are able to join us today because it is PCOS Awareness Month within the United States. And this entire month itself has been dedicated to the color teal to help recognize and celebrate these individuals that have truly had to kind of warrior through acknowledging and treating these different symptoms, especially as research is limited. So I'm excited that you all are able to join us for this topic as we go through the role that we have as physical therapists, and specifically with the pelvic floor. But even if you're not a pelvic floor therapist, we still have a lot of important information that you can do and utilize to help treat these women because you're probably seeing them whether or not you realize it.
Absolutely. Absolutely. So I'm going to go ahead and share my screen over here. And we're going to go ahead and, all right. Are you seeing the presentation? Awesome, awesome, awesome. All right, guys. So polycystic ovarian syndrome, what is it? What are, it's more than periods. And I think that that's what most people think of it as. So jumping right in, these are just a couple of things that we hope that you can get out of this, like just learning a little bit more about PCOS, what it is, how it's identified, how it impacts the major pelvic organ functions, how we as PTs can get in there and help or be a part of the care team because we're not operating in silo, right? We're not operating by ourselves. We are a part of a team approach to addressing PCOS. And then other things that you might see, because sometimes you might be the person who recognizes these things in your patients and they have gone unrecognized for quite some time. So how do we go about addressing that? So it's pretty prevalent. I mean, one in about seven women, so 8 to 13%. Some research says 15%, but in 2023, there was some updated research that showed about 8 to 13% of women, so 1 in 7 to 1 in 10 women are diagnosed with PCOS. And it's expected to be even a little bit higher than that. Like I said, a lot of the time we are not diagnosing, we're seeing women who are undiagnosed. We're seeing a lot of individuals who have not yet had a diagnosis. They've got symptoms. They know that something's going on. They just don't know what the something is. It is the leading cause of infertility in women. And coupled with that, it's oftentimes paired with endometriosis. So that's also another big concern that, again, when it comes to the infertility aspect of it, we may be dealing with one or the other or both. We just never know. And you know, just kind of going off the stats, about 50% of individuals with endometriosis will have fertility issues, and oftentimes they don't. Sometimes they might not even recognize they have endometriosis until they attempt to start trying to conceive. So things to kind of be mindful of there. It's characterized by irregular menstruation, and by irregular, it can span the whole gambit of coming when it feels like, however often that may be, usually less than 8 times a year, to not coming at all. And so for a lot of individuals with PCOS, they can go months without periods, or they can have periods back to back, but typically you'll find that these individuals will have less than 8 menstrual cycles in a year. Um, Again, one of the major findings that the research is showing us now is about more than half of these individuals tend to be characterized as obese with elevated BMIs. And that is going to be something that we need to be mindful of, because then we get into a chicken or the egg situation, as in what's kind of driving symptoms, because persons who are obese will present with insulin resistance. But then we also have persons who may not be obese, and they are also presenting with symptoms of insulin resistance. So again, things to be mindful of when we think about presentation. We can have musculoskeletal concerns. We definitely will have some visceral pain, visceral concerns. And again, like I mentioned, and as you can see here, it generally exists in the presence of other conditions, because it is a metabolic condition, because it is a hormonal condition. Once we have changes within the hormones, that can, you know, especially with the insulin resistance, that can impact the thyroid, that can impact the sex hormones, that can impact a whole host of other things. So sometimes we end up having individuals who have thyroid conditions, who have endo, who have type 2 diabetes, and a host of other things. And so these are things that we need to be mindful of. And sometimes a lot of these things are also contributing factors to the pain that people are experiencing. So when we think about all of this, how do we diagnose? Diagnosis for adults is usually going to be based on at least two of three of these features. It's going to be that they're having irregular periods, which is something that's easily accessible, especially nowadays with menstrual tracking apps and different things like that. We're going to notice hyperandrogenism. So that's going to be more of those androgenic features, especially the increased hairiness. But also sometimes a lot of women can start having hair loss, male pattern baldness, things like that. This can be noted clinically. So this can be just on like a visible presentation, screening, and so on, or, you know, also with blood work. And then it can be also assessed by ultrasound and looking to see the situation is with the ovarian follicles and so on. If we are having multiple cysts, and usually it's more than 20 at a time, then typically what they will, they would consider that as a positive finding. They also will look at the Müllerian hormone, AMH, and that also can be a telltale sign. The difference with adults and children, though, is when we're thinking about kids, we're thinking about adolescents, they only need to have the irregular periods, so oligo or amenorrhea, so irregular periods or no periods, and notice the hyperandrogenism. So with those two, they can be diagnosed. Um, the ultrasound is not necessary because what happens is until you get to about 8 years post-menarche, the follicles aren't really mature. So we're not going to diagnose this in a 12 or 13-year-old. We have to wait a little bit until they've had their cycle for at least about 8 years before we can kind of see more mature follicles and they can get a better idea of what's happening there. So those are a couple of things to also be mindful of. The other thing is that when, again, we talked about this existing with other conditions. So we also want to screen for metabolic syndromes, sleep. We've talked about sleep in a number of webinars this year. It is extremely important. These individuals, again, a lot of them are obese, so they will present with sleep apnea, but they will have disrupted sleep. Now, that could be because of the stress, the anxiety. Depression and anxiety tend to be high in these populations. But we need to be mindful of all of these things to see, what the whole picture is and what is going on. So some of the things that you'll see, I mentioned infertility, we've got male pattern baldness, we've got excessive hair growth, so you get a lot of facial hair, we've got insulin resistance, acne. So a lot of these individuals will have significant acne problems. And then they also can have something that is called, oh my goodness, of course I will go ahead and forget the name now. It is called, I forget the name. Anyway, I will remember. Dionne, do you remember the name of the name for the skin darkening?
No, I don't. I know skin
There
darkening
it is.
impacts
Acanthosis nigricans. And I'm like, it's right on the tip of my tongue and I can't remember. So acanthosis nigricans is a name that's given to skin darkening. So what will happen is, especially like around the neck, telltale sign, they'll have some darkening in the neck creases. And so you'll see this in areas where they have creases, where they have skin folds. There tends to be a significant darkening compared to the skin around it. They'll also have skin tags, things like that. So again, these are some of the things that we will see. The insulin resistance, again, is very prevalent. So you'll hear this as a through and through one of the highlights of PCOS. Oftentimes for these individuals, they're going to do, especially for younger individuals, they'll do oral glucose tolerance tests. What they found is that, in the more recent literature is that this is more sensitive for dysglycemia. And so if they're checking the A1C, that can be missed. And usually they'll check the A1C. They can check it sometimes every 3 to 6 months. But again, it's not going to be as sensitive. They can do the oral glucose tolerance test because this usually it's repeated every couple of years, but it can be repeated way more frequently than that. And what happens is an individual will go into the doctor's office, they'll check their fasting blood glucose level. They'll give them an oral glucose solution, so something very sugary to drink. They'll let that metabolize, so they'll let them sit for 2 hours, and then they'll draw the blood glucose level again 2 hours later and look to see if there are any changes and see how the body is adapting to that. So it's more of a realistic, real-time information versus looking at the A1C, which does take some time to change. And again, some of those signs of insulin resistance, like I mentioned, we get a lot of abdominal fat. So again, kind of pairs with the obesity. One of the things that you'll find is these women tend to have larger midsections. That also in turn, again, cyclical events that also in turn can impact what is happening because that adds to insulin resistance. So as they start to get more abdominal fat, that in turn drives the insulin resistance. The acanthosis nigricans, like I mentioned, they can have skin tags and a lot of dark marks, especially on the back of the arms. That's usually a lot of little bumps on the back of the arms, dyslipidemia, and again, like we mentioned, the menstrual irregularity. I'm going to let Dr. Dionne go ahead and talk a little bit about how the pelvic floor is impacted, but I do want to mention that typically when we think about the management of PCOS, we usually will see a lot of individuals being placed on metformin. They may have hormonal therapies. They might be placed on oral contraceptives. They may start getting the GLP-1 medications. They might be placed on NSAIDs for pain management because, again, when we think about the weight gain, the insulin resistance, it's usually a recipe for significant inflammation within the body. So these individuals may start to present with some pain. Again, we talked about that musculoskeletal pain and visceral pain. So they'll start to present with pain. So then these individuals end up taking quite a bit of NSAIDs for pain management. So these are some of the things that are pretty typical. But as we go through the rest of this webinar, I hope that you'll start to see that there's some other lines of defense that we can employ in order to address this whole diagnosis and this entire syndrome.
Awesome. So when discussing how the pelvic floor is impacted by PCOS, just as Dr. Martin mentioned, we're going to discuss some things that include lifestyle factors in a bit. But we have to take note that a lot of the complaints that we see with PCOS are similar to things that pelvic floor therapists are already familiar with. So that includes pain with intercourse. That includes having incontinence. That's both for urinary and sometimes bowel, depending on if an individual is suffering from like IBS and they're not able to control the loose stools. These individuals can have complaints when it comes to urgency, both urinary and bowel urgency, painful periods with dysmenorrhea, back pain, hip and pelvic pain. And why? Because yes, it can impact the musculoskeletal system, but also we have to take into consideration that our metabolic system is going to impact how our nerves are functioning as well. So there are a lot of things that go into this, including lymphatic flow, which we'll talk about in a bit. So a lot of times what happens when it comes to understanding pain, especially within the pelvic floor, when inflammation occurs, we know that something called a guarding loop can occur. So this is in response to the inflammation. The pain happens. When the pain happens, we have the urgency. When we have that urgency, then the individual can typically try to shut that down. So they'll try to fight that urge in order to go, which can lead to constipation. That also can lead to tightening of these muscles because now the muscles, they have to become overactive or they start tightening a lot more frequently than what we would like. And that can lead to some issues with coordination. So it may sound simple as, well, if you have to go, why don't you go? Because that's not always the best answer. Because if you're in the middle of doing a webinar right now, and let's say you had the urge to go, I can't just get up and leave. But I have to be able to, one, maintain the urge because it may not be socially appropriate for me to go right now. But I also have to make sure that when I get there, I'm able to relax those muscles. But what happens with a lot of these individuals that now that they are actually in the area or in a situation where now they can relieve their bowel or bladder, depending on the situation, they may have overactivity and their brains may not be able to help provide the signal like saying now is a time where you can relax because those muscles no longer know how to relax. So this can lead to increased pain within this region and increased overactivity with these muscles. We also have to take into account that generally speaking with constipation and also with individuals who want to power pee, so they're pushing when they have to pee, that can change and cause an increase in the intra-abdominal pressure. So that is the pressure within the abdominal cavity. So if I were to ask you right now to take a deep breath and then hold your breath and push and bear down, that is you increasing the pressure within the abdominal region. And you may even feel pressure below, especially if you're sitting, you may feel those muscles kind of push below. Well, the problem with this is that when you're having to have a bowel movement, you need to defecate, or even when you need to urinate, we want for these pelvic floor muscles to relax. But if I'm causing increased pressure, my pelvic floor muscles may not be able to relax, causing a dyssynergy with these muscles. So now the muscles are trying to contract when they actually should be relaxing. That is further going to contribute to the overactivity of the pelvic floor muscles, increase the pain as well, and also make defecating or urinating more challenging because you may not allow for complete emptying of those structures as needed. Some other things that we have to be mindful of is that when it comes to PCOS, we know that these individuals, like Dr. Martin already mentioned, are at higher risk for certain comorbidities such as endometriosis, thyroid disease, but that also includes digestive diseases such as IBS, okay? So be mindful that those different things may be a contributing factor, but that should be no surprise if you're already treating pelvic floor because we're used to seeing those patients. So for the next slide, when it comes to the bladder, we already talked about a little bit how these muscles can begin to guard and become overactive. If someone's telling you that they're having a burning like sensation, don't immediately jump to a UTI because it is possible for individuals to have symptoms that mimic a UTI, such as that burning pain or even the inability to completely empty the bladder, and it be related to the pelvic floor. So if you want to rule in or rule out a UTI, you actually need to have a culture versus us just giving these patients antibiotics. Because if we're just giving them antibiotics without truly diagnosing this in a proper manner, we may be doing more harm than good because while we may make their body a bit more resistant to certain strains, and then also we can destroy their gut health depending on the number of antibiotics and also the type as well, which can further complicate some of those bowel symptoms, okay? So if they're complaining of burning like symptoms, try to figure out what are the causes, what are the triggers, how long has this been going on? Is this related to, a lack of water? Because sometimes if someone is dehydrated, then that can cause this sensation as well. And you want to make sure that the concentration of the urine is not too high as far as the acidic level, because that can definitely make them burning like sensation. You also want to be mindful that if someone is constipated, that is going to impact how their bladder functions, okay? So constipation can actually make urinary urgency and frequency worse. Constipation in some cases can also contribute to that of incontinence when it comes to the bladder. So being mindful that we need to make sure that when we're addressing the bladder, we're also looking at the bowels. So what can we do with these individuals? Some people really will respond well to you minimizing or eliminating caffeine in their life. And yes, that includes carbonated drinks, including the carbonated water. I actually remember with my oldest, I had some postpartum complications, and I ended up with a kidney stone because I was severely dehydrated from other things. And the dehydration itself, I really like the fizzy water because that's something I could actually drink. But guess what? My kidneys didn't like the carbonated water. So because my kidneys didn't like it, my bladder didn't like it. So you have to take into consideration that when we say carbonation, we're not just talking about the highly sugary sodas. We're also talking about those things such as water, because the carbonation itself, the bubbles itself, can cause irritation. Being mindful that how our nervous system responds is going to contribute to how the bladder responds. If you're feeling really anxious, if you're noticing that you're also not sleeping as well, then that can lead to your bladder being overactive simply because of some of the actual loops that exist with your nervous system. So generally speaking, if an individual is anxious, what do we start to do? We start to actually clench, we start becoming more tight and tense, and that leads to our pelvic floor also becoming tighter. And now because our pelvic floor is tighter, that the tightness itself can actually cause more compression against the urethra as well, mimicking what some people may notice as a burning sensation. Others may notice the increased urge to go simply because the muscles are not being able to relax. So being mindful as to those different things lifestyle-wise can contribute to it. But how do we figure it out? With these patients, a lot of them should be given a bladder diary. So you want to get an idea as to how often they're urinating and how much. The best way to figure out how much is not to do the count. I know the count is really quick and easy, but it is possible for someone to power pee and to push out a whole lot of fluid in a short period of time compared to someone else who has a much slower stream, but it's taking them a longer period of time to go. So the time is helpful, but it doesn't give us the whole story. So if you're able to actually measure using like a bladder hat inside the toilet, or even using like a measuring cup, how much urine output someone has, that will give you a better idea as to what is going on, because that can tell you more information as to whether or not bladder urgency is truly an issue, or if they have overactive bladder as well. You want to find out with their bladder diary, what are you drinking? Because if someone is drinking a pot of coffee in the morning and another pot of coffee in the afternoon, and they're complaining of these symptoms right after they drink the coffee may be the cause. But if someone also on the opposite end is not drinking any fluids at all, and they're telling you, well, I constantly have this urge, then it may more so be that the concentration of urine is much higher. And because of that, they may be having the irritation of the bladder lining. So trying to kind of tease those different things out so that way you're able to better support and address some of the lifestyle issues. Now, depending on what the bladder diary and also what you uncover from your subjective from the patient, that's going to tell you whether or not you have to do bladder retraining. Do we need to teach you that you're going to the bathroom too often? So if someone is saying, oh, I have to go to the bathroom every 20 minutes, that's too often. Why? Is it because they're consuming a large amount of fluid at one point in time? Or is it because now they've taught the body and conditioned the body to go that frequently? And if that's the case, there are different urge suppression techniques that we can do in some cases. And there are also some distraction techniques that we can implement. So it's important that we figure out what the bladder situation looks like on paper, and also speaking with the person, we can develop the best plan for them. So bowel health, you already heard me mention when it comes to bowels that this can directly impact the bladder health as well. We want to avoid constipation. One big way to avoid constipation, drink plenty of water and also make sure you're getting enough fiber. But even as physical therapists, we have to take in the physical portion of that. So my physios, we have to get moving, teaching people the importance of exercise and how that can impact your bowel health as well. Because when we are constipated, these individuals were at higher risk for back pain and hip pain. They're also at higher risk for our women at higher risk of having prolapse. With these women as well, because to how much time they may be spending on the toilet, and simply the way the toilet is made with the cutout hole in the middle, and also now all the pressure of trying to push and strain, they're at higher risk for hemorrhoids. And hemorrhoids are when you start getting some of the swelling of the blood vessels within that region, and they don't have to be just external in order to be diagnosed. It is possible to have internal hemorrhoids that are often missed. It can make bowel health even more challenging. So we want to make sure that people are getting enough fiber, people are getting enough water, and they're getting enough movement. And the bladder diet we talked about earlier can also include their bowel health. So what do their bowels look like? Where they fall at on that Bristol stool chart? Does this person need more fiber? Does this person need more water? We know we typically want them to be around a type 3 to 4, so that way the stool itself is more like a sausage form. That lets us know how healthy, as far as how their body's actually processing. In some cases, if individuals are saying they're constipated, there are different things that you can do manually as well, which we'll talk about in a bit. So if you don't know what a squatty potty is, it is okay. A squatty potty can be very helpful for these women. A squatty potty is simply like a little stool that you use underneath your feet that will help bring your knees up slightly above the hips and also allow for you to have your knees turned out a little bit. So that way, if you need to lean forward, you can lean in. That can allow for the pelvic floor to lengthen and relax. So now that having a bowel movement will be much easier and you're not having to strain. I typically like to teach people what I call like the long O breathing. So you're going to sound like you're on the opera, but it can be very helpful. And I teach this not just for constipation, but also for labor prep as well, because those muscles we need for them to relax. So if they're breathing, they want to hold their breath, I'll have them take a deep breath in. On the exhale, go, oh, so that way they know they're not holding their breath, they're not bearing down, and that long O sound, just because of how you're utilizing the vocal cords, can allow for the pelvic floor to remain a bit more relaxed even as you exhale. So when it comes to sexual function, we do know that a lot of women with PCOS do suffer from pain with intercourse, and this can be for several different reasons. Sometimes anxiety is a contributing factor because if you have one painful experience, a lot of times you begin to associate that's going to happen again in the future. But even for that very first painful experience, we know that it can be related to the muscles being tighter. It also can be related to the nerves simply being overactive. We discussed earlier how insulin resistance is a common sign of PCOS. Well, with insulin resistance, we have to consider how that impacts our blood vessels and how that impacts our nerves as well. So this does not exclude the nerves in the pelvic region. So these individuals may have heightened sensitivity, and they may benefit from desensitization-based techniques. They may also benefit from some of the things that we know that pain science presents as far as us understanding the type of pain they're having, because the type of pain they're having is going to dictate how we're treating. And when it comes to sexual function, we want to make sure that we're addressing the pain portion. A lot of times with PCOS and other female-based conditions, women only have the sexual component addressed when they express that they want to have children. And yes, that is an important thing, but fertility is not the only important factor when it comes to sexual function. Intercourse is meant to be enjoyed, and we want to make sure that these women, if they choose to participate, that they are able to enjoy that activity without having increased pain. So pelvic congestion is something that actually most people do not think about, and this relates back to with being insulin resistant. We know that it has the metabolic component, but we just mentioned how that impacts the nerves and also how that impacts the blood vessels. It does impact your lymphatic system as well, and we know pelvic congestion can have a relationship to all three of those structures. So it is important that if these individuals are saying that they're having a lot of pain, a lot of pressure in this region, if they're having dull aches that occur that necessarily are not associated with their cycle, but if they're telling you that they're having withstanding pain for a certain period of time after participating in intercourse, or even if they're utilizing tampons and they're noticing that they're having pain that withstands even after removing a tampon when their cycle does come, you want to make sure you're having these conversations. In some cases, some people will even report swelling as well. But it is possible to have all of those symptoms, have pelvic congestion, and not have what we can visually see as far as swelling. So we need at this point to make sure an individual is having diagnostic treatment, to receive an ultrasound and MRI so that we can rule in or rule out what may be some other potential causes. Because at times, yes, lymphatic based treatment is needed, and lymphatic massage techniques can be helpful for some individuals, but long standing, a lot of these people really do benefit from compression based techniques, which can be something as simple as finding a good pair of compression shorts for this individual. If they're noticing that they're having some more of the vulvar varicosities, even utilizing I can't remember the name of it now. It's pretty much the equivalent of the female jock strap. I know that's one version of it, and they can use that to help provide pressure right at the vulva to help decrease some of the swelling that occurs in that area. It is important that even with these people that we are addressing constipation, because if they're not having their constipation addressed and they're having already these signs of congestion and now they're straining on top of that, because of the congestion, they are at higher risk for prolapse and also higher pelvic organ prolapse and also rectal prolapse. So we want to make sure that we are taking the time to address those.
All right, so we're going to go into some interventions, and Dr. Dionne covered a lot of these things, but we're going to highlight some of the things that I like to call it the low-hanging fruit that we can go after when it comes to these individuals dealing with any of the pelvic organ concerns. First and foremost, we can look at just lifestyle management. How you live is everything, right? We've got one body, we only get one, so we've got to make the most, out of it as we can. And so what we found is exercise, specifically resistance training. There's a lot of research that has come out about resistance training that has shown that it is a very, very effective in addressing insulin resistance. The more muscle mass you have, the better your metabolic, the better your body can metabolize foods and different things like that, nutrient sources, the less insulin resistance these individuals tend to have, or at least the better managed it can be. So looking at cardio training, looking at resistance training can be very helpful. Stress management is very important because when you think about the length of time that it takes for someone with PCOS to be diagnosed, add to that if they're dealing with PCOS and any other diagnosis. For example, the average time to diagnosis is about 10 years for endometriosis. We know that a lot of individuals with PCOS will also present with endometriosis. And so when we think about how long it can take an individual to be diagnosed, how much stress they're going through, not knowing what's going on in their body, the frustration of trying to conceive and not being able to, the stress that can place on a marriage, different things like that. These individuals do need some help with stress management. Mental health therapists are very important here, but also looking at how we can manage how can we manage their stress and their anxiety? How can we manage what's going on in their day to day? Sleep hygiene. Sleep is going to be related to the amount of stress they have. The higher their stress, the less likely they're going to have great sleep habits. We want to make sure they're having at least about 7 hours of sleep. If they can have more, that is fantastic. But it's really more about the quality of sleep that they get. If they can get 7 hours of solid sleep, that is fantastic. Versus if they're constantly waking, their sleep is disturbed, they can't get to sleep well, they're tossing and turning all the time, because in those cases, they wake up and they're not very rested. Setting a bedtime routine and really having some sleep hygiene. There's a saying that TV is meant for the living room, the bed is made for sleep and sex. So making sure that they are, when they're in bed, they're in bed. We're not doing anything. We've shut down blue light, so phones, TVs, those types of things, at least a couple hours before bedtime. We're trying to make sure that we're not consuming any fluids before bedtime to help with the bladder control and different things like that. As far as their nutrition goes, these individuals benefit significantly from utilizing nutritionists or from really, really well planned whole food diets. Very easy resource that you can recommend to clients is the Whole30 diet, which is realistically meat, fruit, and vegetables. No grains, no nuts, no seeds, meat, fruit, and vegetables, but as whole food, as close to whole food as possible for these individuals, avoiding processed foods, avoiding sugar, low carb lifestyle, low glycemic index food. So even when it comes to like the fruits and the veggies, low glycemic index foods. A lot of the time, these individuals will be recommended to supplement with inositol, which really does help with managing their blood glucose levels, but also omega-3s and vitamin D can be very, very helpful here. As far as we're concerned, our role is not just to look at the physical, but like I mentioned, we have all these lifestyle changes that we can recommend to our clients that they make. We want to make sure that they can, we can improve functional participation, helping them not only within their normal day-to-day activities, but work-related activities, life-related activities. We want to make sure that we can keep people doing the things they need to do and the things that they love to do. So whether that's work, recreation, or whatever have you, we need to be able to manage pain. And there are a lot of modalities that we can use, from manual therapy to TENS to dry needling to all these different things that we can use to help with pain management. But we know that there's going to be a role for us here. Musculoskeletal support, again, strengthening, really utilizing our skills to help with guided progression of strength training so that we can get these individuals to a very good, stable program that they can continue on their own. And sometimes it might be us starting, just doing some stability work, because these individuals are coming in with back pain, hip pain, whatever kind of pain they have, visceral pain, all these things. And we're really just trying to help them to be able to tolerate movement. But as soon as we're able to layer some strength onto that, we want to try to do that. Your genital support, again, making sure that the organs are functioning the way that the organs are supposed to function. That is what we need to do. And we'll talk about that in a little bit. And Dr. Dionne has highlighted some of that already. Education on pain science. When people are dealing with chronic pain, oftentimes it just becomes frustrating. It becomes very, very stressful. We need to help people understand pain. So one really good analogy I tell people is your body is hardwired for protection and self-preservation, right? If we and think about children. Children are the greatest example of this. Kids don't do anything that hurts. If a child passes by a stove and touches the stove and the stove is warm, guess what? They're going to avoid the stove like the plague. They're not going there because you know what? The stove hurts, right? But in the context of real life, can we avoid the stove? We've got to cook, we've got to feed ourselves. So now we have to kind of find a way for our brain to recognize, okay, this is not inherently a danger, but we need to be mindful of how we use and utilize it. And the same way with pain in general. Pain is a warning sign to our body. When you start feeling pain, it's like a car's check engine light coming on. We need to take notice. We need to tell our body that there is, we need to make sure that our brain understands what is truly a threat and what is not a threat. Because oftentimes when we're dealing with chronic long-standing pain, we get into a lot of pain catastrophizing presentations, and we oftentimes start to see a lot of avoidance behaviors, right? That people I don't want to do it because it's going to hurt, so I'm not doing it. But that's no way to live life. And so our goal is to try to, again, going back to the functional participation, our goal is to get them from potentially the catastrophizing, potentially the I can't do, to, okay, I can participate, I can function, I can do these things. Oh, wait a minute, this doesn't hurt. This is not contributing to my pain, and helping them to recognize the things that are not threats to the body. And again, thinking about those lifestyle management things that we would have mentioned earlier. When we think about the bladder, we just mentioned the bladder, but there is a lot of good research, such as the 2023 Cochrane Review and another article that came out in 2024 that talked about the combination of bladder training, right? Because again, remember, the bladder is a muscle, so we can train it, and behavioral training. So those urge suppression techniques, those distraction techniques, is the most successful tool that we can utilize and should be the first line of defense when it comes to addressing any type of bladder issues in general. But definitely with PCOS, right? So medication may be getting utilized. Doctors might recommend certain things, but medication by itself is insufficient. And so what the research has shown us is that our bladder retraining and our behavioral training is very, very helpful. This is just an example of urge suppression. So just, you know that the urge is there, encouraging your patients to breathe, right? Can we take an inhale? Can we pause? Can we take a long exhale? And as we exhale, can we just gently relax that pelvic floor? And as we do that, it could be with a loud oh, or it could be with a hum. Can we wait? Can we repeat that several times? Can we wait about a minute to 2 minutes, right? And then can we walk calmly to the bathroom? So that what we're trying to do is establish a sense of control over our bladder. Our bladder should not be like an angry toddler dictating what we do. So we want to make sure that we can control the angry toddler, if you will. For those of you who have young kids, you understand the reference. But we want to make sure that we can control the toddler and control the bladder, if you will. Time voiding is going to be helpful. So sometimes a lot of these people with urinary frequency, they are going to the bathroom quite often. Can we, and this is where that bladder diary is really helpful. What is their norm? Where can we start them? And then from there, can we train them? Can we increase it? Maybe they're going every hour and a half. Okay, cool. Let's go every hour and a half. Now, can we increase that to an hour and 45 minutes? Can we increase that to 2 hours? Can we increase that subsequently at some point in time up to 3 hours, which is the average time for voiding? Right? Can we talk about what their toileting should look like? So they shouldn't be breath holding when they're trying to be on, when they're on the toilet. They shouldn't push to pee. We want to address the bladder irritants. So caffeine is one of them. Carbonated beverages are another one. But artificial sweeteners are a huge irritant. Look at all the processed stuff that people consume, right? So tons of artificial sweeteners. And you always have the things now that come out that says low sugar or no sugar, sugar-free, right? But then it's loaded with aspartame, which is a known bladder irritant, right? So we need to be mindful of what we're putting into the body. You are what you eat, truly. And then also, can we get them to front load their fluids earlier in the day? So get up in the morning, have some water. Go take your shower, that'll help you jumpstart your digestive system. You go to the bathroom, whatever have you. We make sure that we have our water earlier in the day instead of constant sips throughout the day. Pause intentional breaks to have some water. And then making sure that we stop water intake about 2, maybe even 3 hours before bedtime to also help with those overnight voids. Again, thinking about the pelvic floor down training, and this can be a lot of vagus nerve work, a lot of breath work, a lot of visual imagery, different things like that. So again, thinking about as you breathe in, relaxing the pelvic floor. So thinking about widening and softening the pelvic floor. And you can also pair that with that urge suppression. And then load management. It's not what people do, but how they do it. So again, exhaling on the effort. Oftentimes, these people may have visceral pain. So now they go to do stuff. They go to bend to pick things up off the floor. Laundry will not do itself. So now, how do we address that, right? And so now helping them to start to implement some of these things to control the intra-abdominal pressure, to help with the relaxation, to help with the engagement when necessary. Doing all these things now as they start to return to functional tasks. As far as their bowels go, again, utilizing that Bristol chart, a bowel diary can be helpful. Oftentimes, you'll ask patients, well, how often do you go to the bathroom? I think I go every day. I didn't go today. I didn't go yesterday either, but I think I go every day, right? And so, again, this sometimes can be helpful. It takes the guesswork out of it, but not only are we looking at how often they're going, we're looking at the type of bowel movement, we're looking at the time it takes them to have a bowel movement. So, are you on the toilet just sitting there for like 10 minutes before anything happens? Is there a lot of increased effort on your part? Do you have to strain? Is there any blood that is visible? Is there any pain, either with the bowel movement or even after the bowel movement? So, really trying to get an idea of what that looks like. And then educating them on their toileting mechanics. We talked about the potty stool or squatty potty, knees higher than the hips. Exhaling on the release. So, taking a deep breath in, then exhale, relaxing and releasing at the same time. Because again, if they're straining, and when they're pooping, they're going to guard. And instead of relaxing, they're going to squeeze, they're going to tense up, and that makes it harder for them to evacuate. The other thing that we may have to do is we might need to use some sort of biofeedback in very severe cases with these individuals who may have dyssynergic defecation. And what the evidence shows us is that it is very, very helpful when we have that straining, incomplete emptying combination. This is very, very, very helpful. As far as sexual function, we talked about down training. It works here because, again, think of the pain. I will not do anything that hurts. The body's job is self-preservation. If it hurts, we are not doing it. Sex is included in that. So again, down training can be very helpful here. Lubrication and using it generously. A lot of people oftentimes think, oh my God, if I use lube, something is wrong with me. This is where it's helpful to talk to your patients about how this can be an adjunct. This can be a helpful tool. It doesn't take away, it can enhance. So we're not taking away, we're just trying to enhance. So thinking about fragrance-free lubes, so your water-based lubricants, your oil-based lubricants, your silicone-based lubricants. We've got a lot of different types out there, depending on where they are, depending on what their needs are, depending on their sensitivity. You may be able to recommend an appropriate lubricant for your patient, or even just assess what they're currently using and give some feedback there. We need to be able to utilize positioning to our advantage. Sometimes sex hurts because of just how you're doing sex. What does sex look like is a beautiful question. It's a very open-ended question where you allow that person to feel comfortable. You don't have to feel like, oh my God, am I prying so much? But just asking them, what does sex look like for you? Do you have pain in this position? Can we make some modifications? We can use pillows. There are pieces of furniture that can be utilized. We can change position. We can talk to them about that, especially if they're having musculoskeletal pain as well. This is going to be very helpful. And also considering when we have sex, is there pain? Is there pain during? Is there pain that lingers after? Pain should not be lingering after. And a lot of the time, what you will find with these individuals with pelvic congestion syndrome or any type of the visceral pain, the abdominal pain, they tend to have pain that lingers beyond having sex. So we may need to scale back. We may need to decrease the frequency of intercourse to make sure that we're not exacerbating the pain. So again, doing that more of a pain as a pain management strategy as well. We can utilize graded exposure utilizing dilators. This is going to be helpful. And just introducing them, coupling that with down training, coupling that with just external touch with the dilator, external application, again, to start to train the brain to recognize that these are inherently safe and these inherently do not cause us any pain, and then start to gradually introduce dilator work. So we're going from smallest to largest based on tolerance for these individuals. We oftentimes will do a lot of manual therapy, a lot of myofascial release. Myofascial release, we need to make sure that the lumbo-pelvic hip complex can move. It all works together. Your hips don't lie. If your hips can't move, we have some problems. So we've got to have good mobility. The other reason for this is if those muscles are activating, they in turn act almost like a pump, and it helps with that fluid congestion. We need to make sure these people can move. Be mindful of just saying do Kegels, because if these persons have high tone, we are making it worse. Sometimes we need to learn to gain awareness and gain coordination before we need to strengthen. We're not just going to say, for example, if we have somebody with a torn ACL post-op, let's go automatically strengthen you. They don't know where their quads are. They have no clue. They can't find them. There's so much quad atrophy, depending on how long from injury to surgery to rehab, they may not have any awareness of their quads. We have to help them to find those muscles. We have to build the awareness, and then we can progress to strengthening. So be mindful of the way that we're doing that. And then most importantly, the team approach. We are a part of a team. Sometimes you as a pelvic PT are going to be the first person to direct them to who they need. The vulva dermatologist, the colorectal specialist, the nutritionist, all the people that might need to be involved. We may be the first person to say, you know what? You've got this going on. Here's who you need to see. So again, build your arsenal of, within your network. Your network is your net worth. So build your network. Make sure you have people that you can refer your patients to, so that they can get the help that they need. So again, ultimately, we talked about the manual techniques, our down training, our TENS, our dry needling, all that to say we've got a lot of things that we can do, a lot of tools within our tool belts that we can pull out to help work with these patients. Now I'll let Dr. Dionne take it from here.
So, is internal necessary? For my pelvic PTs, y'all are going to say yes. Yes, it is. Well, as a pelvic PT, I'm going to tell you in some cases it is very beneficial, but if it is not possible, then you still can treat this individual. And that is important to know because these people are seeing more than just the pelvic PTs. They're seeing orthopedic physical therapists as well. And we want for people to understand the relationship that comes along with the pelvis and with different pelvic based conditions as far as how people present in the clinic. Because individuals in the clinic may come and say, yeah, I have back pain today, or my back pain is worse when I'm on my cycle. And that is when we go back to some of the lifestyle management techniques, because we already talked about how increased inflammation in the body caused from stress, lack of sleep, poor diet. All of that could increase prostaglandins, which of course is going to make uterine contractions during your cycle more painful. So what can we do? We can advise on that end, but we also can do some hands-on treatment with these individuals as well. And so for the next, I'll go to the next slide, just so that way you can get an idea as to, this is the proximity for some of these pelvic floor muscles. So these are the things that we can generally impact externally. Yes, we can impact these muscles internally, but we also can have an impact with these muscles externally. So doing various different soft tissue techniques directly at these areas, teaching people how to serve as their own feedback. So if I have someone sit on a pillow or sit on a towel, are they able to feel how the pelvic floor should relax down into that pillow or towel whenever they go to inhale? Are they able to feel how they should gently lift when they exhale? But now if I want the pelvic floor to stay relaxed on the exhale, am I able to teach them that so now they have their own way to sense the feedback and they can do exercises at home? Especially in some instances where you may notice that people may not have the ability to physically come see you. So how are you able to utilize different virtual treatments so that way now you can help impact people? And this is a treatment that I've done with people over a computer, even over the phone before, just instructing and saying, hey, I want you to grab a towel, roll the towel up, sit on top of the towel. I want you to take note as to what you're feeling. Here's what you should be feeling. Let's locate those muscles. And that can take time, especially if someone has a lot of tension, because sometimes you have to teach them how to relax. And if you're teaching someone how to relax by simply telling them just relax and let go, that's going to frustrate them because they don't know how to relax and let go. So one thing that I tend to tell people is, got it, your body wants to be tense. Let's lean into that tension for a little bit. I want you to clench your jaw. I want you to grip your fist. I want you to push your feet down to the ground, squeeze your butt. And you notice how, if you're not already doing it, go ahead and do that way you can just get an idea. And everything is tight. And then I'll tell them, and now let it go. And when they let go of all that tension that they just caused themselves, now they're able to at least have an idea and sense, oh, this is more so what relaxed feels like. And then I'll have them do it again. And now notice what your pelvic floor is doing as you sit on top of that towel or on that pillow. Do you feel it let go and drop down as well? So that way, if you can't see people in person, or even if you're someone who's not comfortable or trained to do internal, that's a technique that you can do with your patient. So that way, now they can learn how to simply relax the pelvic floor, which is going to be key for the down training. And on the next slide, it's more than just the pelvic floor, because when we talk about the surrounding areas, we have to consider everything that we just mentioned. To every front, there's a back, meaning that if someone's complaining that they're having pelvic pain, you probably want to take a look in the gluteal and buttock region as well. If someone's complaining that they're having back pain, you probably want to take a look at the abdominal region. But even considering where those muscles attach, the inner thighs at the adductors, you can have a lot of trigger points in those regions that can also cause for more pelvic pain, because now you're going to have more tension in the pelvic region. So even doing different release techniques around some of the surrounding musculature can be very beneficial. So do you have to do internal? It may be beneficial, but it's not necessary, especially if you're not trained in it. So I don't want you to think that if you're not trained in internal techniques that you can't have an impact, because you can. Because you're going to be the one having the lifestyle management and lifestyle modification conversations with the patient. But now you also can utilize your orthopedic and musculoskeletal knowledge to help come alongside to benefit these people. So don't forget the simple orthopedics. Don't forget that understanding how the musculoskeletal system relates to the pelvic floor, which has musculoskeletal systems as well, how all of that relates to one another, so that way you can help people ease their tension. Because I've seen it time and time again. People are tight in their hips. If they're tight in their hips, which direction are they tight in? They're tight more so with the external rotators. Got it. They're probably going to have some lumbosacral dysfunction. Why? Because we know the piriformis and obturator internus. We also know those two muscles have a direct link to the pelvic floor. But if I'm so focused on just trying to internally treat, but I'm forgetting some external movements that can help, so simply teaching someone how to stretch, how to change positions when they're sitting, how to modify certain activities. So it's not always about internal techniques. It's about treating the whole person rather than just trying to always look vaginally and rectally to see what's going on.
All right, everybody. So for those of you that have hung in here with us until the end, we appreciate you. We thank you. Any questions at all at this time? Feel free to put them in the chat. Feel free to raise your hand. Let me just make sure that the chat is enabled. I do believe that the chat is. All right, so you should be able to chat now if you have any question. But I saw a hand raised. Go ahead, unmute yourself.
So the question that we have, Dr. Martin, is it normal to spot when you have missed your period for 5 months?
Is it normal? No. Does it happen? Yes. Because when you think about what the period is, so if we take a typical, I won't say normal, but a typical menstrual cycle, which could be anywhere from 19 days to 35 days. So oftentimes people assume I'm not 28 days, right? I'm not textbook, therefore something is wrong. 19 to 35 days is the window of normalcy. And then we look at within each individual, what is consistent for you. So if you're coming every 21 days, that is your norm. That's completely normal, right? It might be frequent, but it's completely normal. So we have the follicular phase, right? Where we have increased estrogen, the follicles are ripening. We get to the point in the follicular phase nearing the end where we get to ovulation. We have the release of the egg. There's like a little 5-day window for fertilization opportunity. When that doesn't happen, we end up going into that luteal phase whereby the egg will start to degrade because it's not been fertilized. Corpus luteum will start to degrade because there's been no fertilization, and all that stuff starts to shed, and the lining starts to shed. At the end of the luteal phase, we have, coupled with the decline in hormones, we have a period, what we call a period. This happens in a cyclical fashion. If we are constantly spotting, it's telling us that something somewhere along the line is usually off, because you're not going to bleed continuously. So that just tells us that something somewhere along the line with the hormones is off. If that's happening, I would recommend that person to get checked. If you're not making any leeway with your gynecologist, then I would recommend like a reproductive endocrinologist if there is one relatively nearby, or at least someone even virtually that you could see.
And just to add in there as well, when it comes to missed periods, it's important that we figure out the cause of missed periods because it's not always PCOS.
Mhm.
Sometimes it is poor nutrition, sometimes it is stress. So we need to know more information as to what is causing the missed period. But it's one, never normal to miss. If you're missing, we want to figure that out. And we also want to figure out the cause of the missed period as well.
Do we have any outcome tools to check on sexual dysfunction? So you can use a pelvic girdle pain questionnaire. Oftentimes the questions involved there can encompass sex, but that's usually a validated tool. There is also I forget the name of it. I will try to remember it and let you know. Um, it's a short form, the Sexual Function Index Questionnaire, I think it is.
Yes.
Um, and so that's a really good yeah, the Female Sexual Function Index questionnaire. And then there's one for males, which is the International Index of Erectile Dysfunction. So those look specifically at sexual function, but you also potentially could use a pelvic girdle pain questionnaire, especially if the issue is less with sexual function and more with like dyspareunia or pain with sex. So you could utilize those. And on all of those are validated.
So for the PCOS mechanisms, I did type in the chat. I'll just quickly go over that again. That when it comes to the hormones, that androgen levels are typically elevated, not just testosterone, but also DHEA can also be elevated. But there's also a link that they've noticed when it comes to estrogen and progesterone, and we know that progesterone is needed when it comes to maintaining a pregnancy, which is thought to be contributing to some of the fertility issues. So with the PCOS mechanisms related to hormones, they generally have higher androgens, and because of the higher androgens, they also generally have an imbalance between estrogen and progesterone.
And add to that, then you have the insulin resistance. So insulin is inversely proportional to your sex hormones, as is cortisol. So when insulin is high, then sex hormones are going to be decreased, which also then um, impacts PCOS, which is one of the reasons why the menstrual cycle is impacted. And when you think about that, then you think about, okay, we've got insulin resistance. Well, that tends to raise the stress levels within the body, the inflammatory response mechanism. So now your cortisol levels go up. Cortisol levels are high, so cortisol tends to suppress, elevated levels of cortisol tend to suppress sex hormones as well. So you're going to have suppression of your estrogen and progesterone. You also have to think about then how that's going to impact your thyroid, because your thyroid also impacts your sex hormones. So there's a lot of different hormones that function in the body in some sort of relationship, whether directly or inversely related. And there's a homeostatic balance. So if that gets thrown off, and usually in PCOS it is, usually because of the insulin resistance, then that's usually what impacts the other hormones.
And Dr. Martin, I'm not sure if you see Constantine's question there. As a matter of I don't think I understand the question, so maybe I'll.
So, so as matter, matters PCOS prevention, I believe my bias of exercise, healthy nutrition, sleep hygiene are key in long-term management. So key in long-term management is not the same as prevention because there is thought to be a genetic component and some people are predisposed to having PCOS. Therefore, can you prevent? Possibly not. Can you manage to the point where you minimize symptoms? You could, if you, in some cases, and many people have done this, definitely through nutrition and exercise and all the things that you've mentioned here, which is why we oftentimes will recommend those things because we know the impact that it can have on the body. Um, and then that just kind of lends itself towards long-term management, but I hesitate to say that we actually will prevent it because again, should anything shift, you know, then it has a potential to flare again. So I hope that helps answer that question.
And then next we have, is it possible for one to start symptoms of PCOS later in life, like normal regular periods, then changes later? Yes.
Yes.
There are actually some women who have PCOS who have what we consider to be a normal period. So, is it oftentimes that we see that? No, but it does happen.
Mm-hmm. And then again, remember that this is an insulin resistance issue, but also kind of think about what other time in a woman's life brings about insulin resistance, and that would be perimenopause. And so when we think about that, oftentimes it may not specifically be PCOS because again, to be diagnosed with PCOS, we have to look at the specific factors of the hyperandrogenism, the menstrual changes, the follicular issues. So again, none of that stuff may be going on, but we may have just some insulin resistance. And if that is the case, that in and of itself can be something that can impact menstrual cycles. And again, telltale time for this in life is during perimenopause, whereby women are going to start noticing, okay, I'm starting to get a lot more of that abdominal fat. And when the abdominal fat, that visceral fat increases, one of the things it does is it carries with it some receptors that bind with free flowing estrogen. So it kind of pulls estrogen out of the system. And so now not only do we have insulin resistance, but now we have a decline in systemic estrogen. And so that can then start to mimic all the things that we mentioned as symptoms as well. So that can impact the period. So yes, you could start. Would it be PCOS? It could be, but again, PCOS, that is a diagnosable issue, and one may have similar symptoms that may not be PCOS, but could be caused by some insulin resistance, again, primarily due to perimenopause.
And then we have one that says, what is considered the average time that one can be able to hold urine after the initial urge? And there are a lot of factors that would determine that. An individual's age, believe it or not, can determine it because we know that as we begin to lose estrogen naturally during perimenopause to menopause, that the bladder is not as elastic. So the urge, the ability to hold may be more challenging. Someone's medical history also can impact that as well. So this one is, it depends. I'm going to look at the individual itself and try to make that call. So if someone's telling me that they're going to the bathroom every 20 minutes, that is a problem. We need to figure out why that's occurring. Now, mind you, if someone else is telling me, "Oh, I have the urge to go," and they say, "But and when the urge comes, I can't hold it." When's the last time you went? If they say, "Oh, it was 5 hours ago," then yeah, they probably cannot hold it. That's been a significant amount of time. So the amount of time since someone has last urinated is going to play a factor. The age of the individual is going to play a factor. Any medication that they may be on is going to play a factor. Generally speaking, we should have to relieve our bladder somewhere between every 2 to 4 hours. Now, ideally, it's closer to the 2 to 3 hour mark. Ideally, that way you know that you're hydrating properly throughout the day. A lot of times what you'll see happen is with these individuals, you'll see, excuse me, one or two things. Either people will hold their bladder to the point where they can't hold it anymore because of their occupation. They just can't go when they need to go. and now they have an extended period of time in between going, so now they can't hold it and now they feel as if they're overflowing. Or you'll have individuals who will go to the bathroom constantly and they've trained their bladder to go. And because they've trained their bladder to go that frequently, now we have to take a different approach. So it depends. But in general, you want to urinate somewhere between every 2 to 3 or every 2 to 4 hours. That should be your cue to go. If you're urinating more than that, look at how much water they're drinking and also look at some of the other factors to potentially consider down training if needed, or even working on bladder retraining as well.
On the sleep hygiene question, so the Center for Disease Control here within the United States, along with the National Institute of Health, both recommend 7 to 9 hours of sleep as what is optimal for adults. Anytime you're getting less than 7 hours of sleep, especially given for what the average person has to do as far as daily tasks, home management, work management, different things like that. It starts to then border on impaired safety. Now, can you go a couple of nights with 6 hours of sleep? Sure, we all have. Long term, is it the best thing? Not necessarily, because again, your body is tired. If we are supplementing that with maybe a nap during the day, then potentially it could be okay, because there's some research to support napping as being healthy. Like, your power naps, 20, 30 minute nap during the day, definitely not going beyond an hour. Um, because then that can disrupt your nighttime sleep. But so that can be helpful. But according to the research, it shows the most recent research, it shows 7 to 9 hours. Some women report bleeding during vigorous sex. What causes bleeding and how can it be prevented? Lack of lubrication usually is going to be the problem. If we were already irritated, because sometimes you've got someone who is already irritated, lack of lubrication. So there's almost like that sense of friction burn. And what do? Because it's uncomfortable, they start to clench, they start to tighten. So, then it's like the partner is probably going to go a little bit harder, because now he's feeling that clenching, which either to him is going to signal, oh, it feels good to them, or, oh, I need to work a little bit harder so I can feel more satisfied. So one of the two of those things, and that can kind of lead to it. Sometimes, again, if you think about if the bleeding is more superficial, then it's that stretching at the introitus. And again, if they're bleeding all the time, I would be concerned about low estrogen levels, because that skin is just tearing so easily. So if we're not on the back end of postpartum, like if we're not immediately postpartum or something like that, where we're dealing with like a existing perineal tear, perineal trauma, or something like that, that we know there were sutures, but this is just kind of an ongoing thing, I'd be worried about low estrogen levels in this individual, and just some potential tissue changes going there. Anything to add to that, Dionne?
No, I was hoping you would hit the estrogen piece, and you did. Because that when the moment I saw that, I was like lubrication and oftentimes estrogen. And
Mm-hmm.
the
Mm-hmm.
next question I was waiting for. I've been waiting for this question.
The semi-glutide question.
Yes, because so first let me say there's still emerging research when it comes to GLP-1s. Okay, that's important to note. Um, but yes, these individuals should be doing resistance training. If anyone who is on a weight loss program should be doing resistance training. Of course, these individuals are going to have medical management, but specifically with GLP-1s, I want you all to know that we're seeing research that's emerging discussing how it impacts pelvic health, specifically the vulvar health. Okay, so be mindful when individuals tell you that they're on this medication. Please actually have them inspect, and you inspect if you're able to, the vulvar region, because we're noticing different skin type changes, especially with thinning, with atrophy. We're noticing that sometimes they may have bleeding with intercourse, which can be contributed to the atrophy of the tissue. So this is a conversation that it's pending as far as us gaining more information. But specifically in regards to should they do resistance training in tandem, yes. Um,
Yes,
your
absolutely.
you're giving someone a medication where the goal is to help them decrease weight, but we need to specify the type of weight, because if someone's putting on healthy muscle mass, that is going to help further assist with managing insulin. Okay, if someone's just putting on weight, and typically in these individuals it's adipose tissue in the visceral region, so that belly fat, that is going to increase the risk of insulin resistance, which is what the GLP-1s are hoping to help decrease, and also helping to help manage the weight. But specifically as physios who specialize in pelvic, if you have not already seen, there's emerging research that's suggesting that this is a so yes, we've heard of Ozempic babies where people realized that birth control wasn't effective with why they were taking Ozempic. This, we're noticing some vulvar changes in these individuals as well. So be willing to have the conversation, be willing to educate them on that side effect, because they may not know, and that may dictate whether or not they want to proceed with that or not. And this is not at all for me to tell you that no one should be on GLP-1 medications, because there's a time and a place for everything when it comes to managing the health of the individual. And for some individuals, because of where they are medically and metabolically, we need to consider that additional pharmaceutical medication may be the best option for their health. So we just want to make sure that people know the risk and the benefits associated with it all, so that way they can make the best informed decision. But specifically for your question, resistance training, yes, it should be 100% while they're on these medications, and any medication, unless there's a medical reason as to why we should not, and that is a true contraindication. But also be mindful that it's impacting the vulvar health, it's impacting the tissue and the vascularization of that area. Dr. Martin?
Yeah, absolutely. I see a lot of erythema,
Yes.
vulvar erythema, so a lot of vulvar redness with these individuals. Oftentimes, it looks like the labia are red and maybe even slightly swollen. And some of these individuals also tend to have issues with pain with intercourse. So like some introital tenderness, some superficial dyspareunia, if you will. So I would say if you're having patients on these, kind of get into like a case study, and note what you're seeing with your patients. Um, and kind of make mention of that. So I think it's very important for us to know, because then it helps for us with regards to educating the people that are coming on the back end of this. I know people who need to take Ozempic because, let's say, they need to have a knee replacement and they're overweight. The doctors are not going to do that surgery. So, and then they're telling them, well, you need to lose the weight. Well, it's very difficult for these people to lose weight, especially when we're talking about severe insulin resistance. So sometimes they do need something to kind of jumpstart that process, and kind of help them a little bit, let them lose the weight, so now they're able to have whatever the procedure is or whatnot. So great conversation, great question. All right. I think that's all the questions that we have. Well, thank you so much again for hanging in there with us. If you have any questions, shoot us an email. But we'll join you again next month. Look out for the emails with regards to the information on that. But thank you so much for being here. Bye, guys.